everyone there at Parur University for inviting me to speak something on neurological rehabilitation. And Dr. Inkal Yadav approached me for speaking to you all. I hope you all understand me. So she asked
Right.
me to speak something.
Very much, sir. Sir, we are waiting for this today's session. Please just give a 2 minutes to introduce you, sir.
Okay.
So, good afternoon, everyone. Today we have our guest speaker, Dr. Manoj Kumar, sir, pursuing PhD from Gujarat University and currently working as a professor at College of Physiotherapy, Anand. And he had some contributions to neurological rehabilitation, both in a term of publications, teaching, and treatment. Okay, sir. Thank you, sir, for giving your valuable time. Now you can start the session.
Okay. Thank you, everyone. Thank you, Rinkal. Thank you, Parul University. So CRPS, the topic that I chose to speak on, was a bit close to my heart. That recently I saw around 4 or 5 patients in which the patient was experiencing a lot of debilitating pain, and we as a physiotherapist were not able to give them relief as early as they were expecting. Dear students and colleagues, we should understand that the definition of CRPS has been since quite some time, but the current definition of CRPS is a syndrome that usually develops after noxious event, limited to the distribution of peripheral nerve, disproportionate to the inciting event. Now, most of the time, when look for the inciting event may be very minimal, and thereby patient experiences pain, which is disproportionate to the inciting event. Means there is possibility of a needle, or there is a possibility of small trauma, or there is possibility of some small fracture, or there is possibility of simple pacing movement that might have caused the pain. So this problem is really a big problem that the patient is experiencing, and the international classification of CRPS. All of you must be knowing that the International Association for the Study of Pain has proposed CRPS into two categories. That is type 1, formerly known as simplex reflex sympathetic dystrophy (RSD), or the second is called as quadrilogia. The first also is called as bone pain, and second is called as neuropathic pain. It is also called as algodystrophy. So, without identifiable peripheral nerve injury, if the patient is experiencing disproportionate pain, it could be one of these two categories. So, as you go ahead, you'll find that there are epidemiology, that is, lot of patients are suffering from CRPS. So it is somewhere between 5 to 26 per lakh people is suffering from CRPS. Women's usually suffer more than that of men. It is almost 3 is to 1. Incidences increases as you age. Upper limb 60% versus lower limb 40%. CRPS 1 is around 90%. So causes are usually four: peripheral musculoskeletal, peripheral nerve root, CNS, viscera, and idiopathic. If you see the peripheral musculoskeletal, usually there will be some trauma to the nerve, usually fractures 45%, sprains 18%, dislocation, immobilization results into this kind of pain. Peripheral nerves usually trauma and injury to brachial plexus and other peripheral nerves. CNS usually stroke or TBI results into CRPS. Viscera usually myocardial infarction result into CRPS, and idiopathic, that is spontaneous, there is a possibility of CRPS. As you go ahead, you'll find a lot of signs and symptoms which needs to be categorized. So there's a lot of criteria by which you can say the patient is have suffering from CRPS. One is called as constant pain even at rest. If you ask the patient where is the pain, they will say you that the region which is in where the pain is. More than that, there will be pain. So usually pain is in area maybe more than what we are expecting at wherever there is a trauma. Second is limited range of motion, burning type of pain or stinging type of pain will be seen in this patient. Nail growth changes, nail can be brittle, nail can be tight, or nail can be nail growth can be seen in all these categories. We need to see that the patient can have negative symptom, positive symptom, autonomic symptom, or motor trophic changes. So far as negative changes, negative symptoms are concerned, we as a physical therapist need to know that systemic findings of symptoms have been excluded either by the physician or we as a red flag, yellow flag should be able to find out that there is no systemic reason for this pain. Positive, we all know that we know it by either sensory problems, motor problems, trophic problem, autonomic problem, pseudomotor problem, vasomotor problem. All these are symptoms that is called as positive problems and motor trophic problems will be there. So out of all these clinical features, patients will have complex regional pain syndrome, which is usually notified by a word called STEM. Sensory means allodynia and hyperalgesia. Allodynia and hyperalgesia is a very important features of complex regional pain syndrome. Allodynia basically means the stimuli which is not a source of pain, like touch, pressure, touching of shirts, or saving, that becomes a source of pain. That is, a stimuli which is not noxious in nature is also become noxious. And hyperalgesia, as the name itself suggests, that something that was non-painful or something that was below the threshold results into painful stimuli. So this allodynia and hyperalgesia is a very important feature. Vasomotor and pseudomotor is concerned, that is also very important. Or redness or there will be a lot of skin changes. There will be skin thinning. Okay, and sweating may be there or may not be there. Initially, there will be heavy sweating, and later there will be less sweating. And so far as motor is concerned, there is a possibility of decreased range of motion, decreased muscle power, decreased muscle girth. And with this, we might find that the patient is suffering too much. Then, as you said, there is a three stages of CRPS. Stage one is called as acute stage, which can be within weeks to injury. Then dystrophic phase, which is within months of the injury, and atrophic phase, that is for years after injury. Affected limb may be swollen, red, burning pain will be there, increased diaphoresis of the affected limb. All symptoms are near the site of original injury. Now, as the patient is moving to our second stage, dystrophic stage, the skin of the limb is cool and diaphorate. So initially there will be a lot of redness, there will be a lot of pain, there will be a lot of difficulty, but as you go, then the pain will start subsiding. In place of that, the coolness, the bone dystrophy, and then the tightness will start developing. So skin becomes pale and shiny, atrophy of muscles will take place. Pain may be constant even during treatment. So that is very important feature in stages. Okay, chronic phase, severe motor and traffic changes will be there, and patient may not be uh, finding relief even after uh, a lot of treatment. So in CRPS, inciting event or causes of immobilization can result into pain. Now, this inciting event is very important. It has been seen that the four classes of problems, as I have discussed earlier also, that there can be trauma, there can be surgery, there can be fracture, there can be hand crush injury, there can be small needling or patchy movement that can incite this pain. And pain should be continuous, allodynia, hyperalgesia, and pain should be disproportionate to the inciting event. Evidences at some time of edema, changes in skin, blood flow, pseudomotor activity is also seen. So according to this, if the few factors in terms of acute stage of inflammation dominates, then it is called as acute stage or stage one. And the second is presence of continuous pain, evidence of some type of edema. The diagnosis excluded existence of continuous or other type of pain, that is either radiculopathy or some inflammation of the skin or some inflammation of the bone which has resulted into the similar kind of pain. Then this diagnosis will be coming into causality.
Yes, sir.
Audible?
Sir, sorry for the. Can you tell me the slide number? I'll try to present from my side. Just tell me the slide number from your PPT, sir.
Are you trying to play?
Yes, sir. I will present from my side. Your PPT, I will present, sir.
Okay. 10th.
10, no? Okay, sir. Okay.
Can I, one. Can't see this.
Is it fine, sir?
I can't see now. Rinkel Ranil, I will speak to them.
Okay, okay, sir. It's fine.
नहीं हो रहा. I'm sorry that you might not be seeing the slides, but I will speak slowly. That we all understood that CRPS is important, and their diagnostic criteria also we understood. That by one word, that is STEM, that is sensory problem, trophic problem, autonomic problem, motor problem, and pulses, we can make out that there is a possibility of some sort of disease. If otherwise this symptom is not presented, which is very, very unbearable, excruciating, stinging neuropathic pain. So there is a Budapest. There were criteria earlier that was called Internal Association of Pain Society criteria. Now there is a Budapest criteria for diagnosing the case of CRPS. And out of sensory, vasomotor, pseudomotor, and motor problem, there has to be at least one sign or two or more categories problem, or one symptom and three or more categories problem before diagnosing that a patient is suffering from CRPS. So if I see out of these, like if I see there is a sensory problem and then in vasomotor and pseudomotor there is one symptom, then we can call the patient is suffering from CRPS. But if you have to make some research, probably there has to be one more symptom before we can classify that the patient is suffering from CRPS. This diagnosis is usually clinical, and most of the time it is very important for all of us to understand that this diagnosis can also be excluded by some pathological findings. Pathological findings are very, very important to understand. But we should understand that in pathology there are tests to exclude that the person is not suffering from CRPS. So, what are the basic pathological tests? So, if you take inflammatory markers, most of the few inflammatory markers may be elevated, but that will only show that the other causes are not there. Then, if you take bone scan, there will be some osteopenia present in the area where the patient is suffering from CRPS. And if you take EMG, there is a possibility of myoclonic presentation, or the EMG, the muscles firing may be more. There are multiple tests that can be done, but these tests are usually is not done on clinical basis. Mostly these tests are done for research cases or in higher centers to understand the definiteness and the progressive nature of the disease. As a physical therapist, if we are working in a clinical setup or in even a hospital setup, we usually go by either if it is been screened by the physician, or we see that the Budapest criteria is met, and then we start treating the patient, and we see to it that the patient responds to our few physiotherapeutic technique, and if not, there should be a multidisciplinary team, and to find out the other factors also, which is the part of this uh, CRPS. So pathophysiology, basically there will be a lot of neurogenic inflammation, there will be altered cutaneous innervation, sensitization. This sensitization is very, very important. Sensitization is also peripheral and central. As we use this word very, very commonly, sensitization basically means the receptors which was earlier not painful becomes painful because the brain structures responds to non-painful stimuli, and thereby the patient experiences pain. Even the cutaneous receptors are becoming more in number, and thereby a small amount of touch or some other touch also starts carrying painful sensations. Patient starts experiencing pain. Brain plasticity, there is a reorganization presentation of the brain, especially the cortical area and sensory cortical area. There is severe changes because of which the representation of the painful area becomes too much, and thereby any depolarization of those area results into pain. Sympathetic hyperactivity is too much, and apart from that, there is something called sympathetic sensory coupling. Means as we all know that sensory functions which was normal starts getting attached to sympathetic function. So all sensation, it is touching or pressure or some amount of movement or pressure through the air, all get coupling with the sympathetic system, and thereby the patient um, mm, starts getting sympathetic reactions, and the muscle spasm, and patient experiences pain. Genetics. So far as genetics is concerned, HLA typing has been found positive in 156 patients, and it has been seen that some patients who are suffering from CRPS has got some sort of link with their families, either mother, father, or brother. Psychology. It has also been seen that the people who are slightly emotional in nature, or patient who has got little easily evoked nature, or patient who has got a type of personality which is not very bearing in nature, develops pain, CRPS. So as so if the patient starts experiencing all this pain, we can also see the pain triggering area. We can see sympathetic area. That is why the multiple areas are scanned to see if there is a problem in those areas, so that if those changes have taken place accordingly, the management can be thought of. So altered cutaneous innervation, central sensitization, peripheral sensitization, altered SNS function, circulating catecholamines, inflammatory factors. Now, all these factors are there, which is usually taken care of by anti-inflammatory medications, or they are taken care of lot of surgical procedures. And then brain plasticity, obviously, that takes place in somatosensory cortex. Genetic factors, as I discussed, was very, very important. Psychological factors, uh, anxiety is a very, very important factor. Emotional arousal, people with emotional arousal suffer from CRPS quite often. So, with all these factors in mind, it is very important to understand that the patient who comes to us should first be assured that their pain can be minimized with the help of a multidisciplinary team. So, first diagnosis is very, very important, and thereby maybe for a physical therapist. It could be advantageous that he sees the patient multiple number of times, so when he get to know about the history of the patients, detailed history of the patient, because all these patients, there are very few chances that you might contact with the patient in acute phase or subacute phase or chronic phase, atrophic phase, dystrophic phase, and all those in those phases we'll have little bit of informations And in that information, if you add a lot of tests, then the clinical sign and symptoms become evident. And on that clinical sign and symptoms, if I add the history, if I add the personality type, the genetic type, the neurogenic inflammation, inflammatory markers, and other pathological tests, then I can be sure that the patient is suffering from some form of CRPS. Now, once we diagnose and be sure that the patient is suffering from CRPS, then I will think of treatment. So, treatment is really, I have had a lot of interest in patients because patients really suffers a lot. And our physiotherapy many times increases pain. I mean, if you do movement, patient is very sensitive. So, if a little bit of movement, more or less, the pain bearing becomes really very difficult, and there is nothing much that can be done. Though in research there are a lot of things written, but in practical there is not much thing that is applicable. So the pillars of treatment are usually physical and vocational rehabilitation, patient education, psychological treatment, medications, and other surgical procedures. Now, if I see the pain and medications, there are a lot of painful medications that they usually take. So they may start with simple analgesic NSAIDs, and they might go to their evidences are only of pregabalin and gabapentin, and then there are some evidences of some dorsal root blocks, or sometimes they apply some procedures on the posterior sympathetic roots, or they do phenol block. But the rest of the problems can be tackled with the help of physiotherapy, psychological counseling, or maybe combination of physiotherapy, occupational therapy, and psychological counseling gives early function. And for that, there is a better evidence. So there are not class one evidence, but there is a better evidence, and thereby we should be taking care of this patient with the help of physiotherapy. So in physiotherapy, if a patient has not undergone spinal cord stimulation or something, then along with the medication we start physiotherapy. And physiotherapy, usually the basic thing they do for initial pain management is lot of electrotherapy modalities. Evidences are less for electrotherapy, and that is where probably they go for lot of things. So TENS is one thing. For that there is a good amount of evidences, and I motor graded imagery, second is mirror therapy, third is relaxation, fourth is therapy. All these the first I think I need to collect for what intensive therapist unplanned therapy, because we are clinicians. So in that concern, the pain has models have to understand. why this pain is happening and what are the different things which impacting the patient core and pain. And that is where we need to all the plans that we have said probably whether there is any comorbidities, whether there is a home problem, whether there is work problem, whether the patient is tense or whether the patient is depressed, whether there is cognitive also. All those problems complicate pain, and thereby we as a physical therapist sometimes work in the forefront in understand or sometimes attaching take psychological help so that the patient can relax and understand and hope that there is a possibility of getting rid of this chronic excruciating or disproportionate pain. So if I give physiotherapy and then if I give most of the time I give burst tense, and some of the time if I give high tense for 20 minutes or for 20 minutes, so almost 5 days a week for 3 weeks, there is a great amount of reduction in pain. So far as active assistive range of motion is concerned, patient has a lot of times phobia and patient will be unwilling to do the movement. So if the patient can do of his own, it is best. But most of the time, the patient has inflammatory process and patient also has phobia. So because of these two things, there is possibility that we as a physical therapist should help the patient in initiating the movement. And maybe we should do the movement in the area where the movement is easily possible, the patient can do. And then probably can start to go into the area where the region of maximum pain. So as I start doing movement, the pain itself will the movement itself will block the painful sensation. And if I do not go to the region where the patient experiences pain, there is a possibility, and I have seen clinically that the pain sensation becomes less and less. And as the range of motion improves, and the control of limbs improves, the patient feels better. Then there's sometimes graded motor imagery. Graded motor imagery is also, if simplest way of doing it is probably imagination of movements and then relating of movements. Movements can be related like how it feels the movement, how the movement is felt in relation to the environment, how the movement is felt in relation to proximal and distal, how the movement is felt in relation one movement to that of other movement, how we can discriminate left and right. And by merely thinking, there is a stimulation of the brain cortical cells. The brain cortical cells starts reproducing. Obviously, it will replace the area which is, or probably it decreases the inflammatory process or sensitization process in the brain. So thereby, a lot of graded motor imagery technique really helps. And though the studies are of 2006 and 2010, but they have shown that there is promising effect of graded motor imagery that can help in the patient. At least the patient who are acute and subacute in nature, they will not go into chronic stage of excruciating pain and repetitive pain. So there will be some sort of reversal in the pain intensity, and sensitization will also become less. So there is a possibility of patient experiencing early joining in movement and thereby functional movement and independence. As a physical therapist, also, if I do graded motor imagery, participation of patient into function by either occupational therapy, self, or by us will be better. Family-centered therapy also helps, as it is considered to be hope for the physiotherapy. So it is a prophylactic intervention also. So left-right discrimination, explicit motor imagery, mirror therapy, all can result in the regain of functions. So there's a possibility that patient only difficulty with this technique is sometimes the patient cannot understand. So it requires high level of involvement of the patient, and thereby the patient experiences pain, looking at an image, and then you find different image, and that will be reduction in the pain. The patient may experience pain, go back to the other area of the training, and thereby patient will experience less pain. Mirror mirror therapy also, as we give mirror therapy in other condition. In this condition also, the patient can experience doing movement on the normal side first, and then the patient starts initiating movement on the affected side. So this mirror therapy, uh, along with the graded motor imagery techniques, helps a lot in regaining functions. Now, accuracy of identifying of the body must be above 80% if this graded motor imagery has to work. So, if the patient mood is good, if the patient thinking is in present, if the patient is totally into present, then the possibility of graded motor imagery technique is quite high and they work quite well. So far as patient starts gaining the control over his limb, then some form of other therapy, like if there is a edema and slight amount of elevation, then doing exercises might help. Elevation, exercise, and tense can be combined, and that also helps in decreasing the pain and edema. So, with this, we also tell patients to practice all these movements at home. And if the patient practices most of the time at home, where the inciting event or the exercises do not result into increase in pain or edema or stiffness or decreased range of motion, it means the patient is progressing rightly. So every day, we create some sort of diary for the patients. In all the chronic patient, if the patient becomes very, very concentrated and patient becomes involved in his own management, then there is a possibility of reversal back of the symptoms. So I then if all these starts working, then probably I probably sometime tell them to purchase a mirror therapy, and the first level they might do at home outside of the mirror, and then can do it inside the mirror, and then both the limbs they can do it, and they can do it independently at home also. So mirror therapy and graded motor imagery can really work wonders in gaining the control of the hand function. So patient can be made independently if he is very, very participative. Sometimes what happens that we as a physiotherapist need to work in consonance with the other professionals. Like other things might be going all right, but if the patient is not if the patient is not following the command correctly, or if the patient is not very, very hopeful, then psychologists, psychiatrists, or medicine of the nature which can decrease the depression, like in that cases, especially tricyclic antidepressant works quite well. Anxiolytic drugs works quite well. CBT works quite well. Then behavior modification works quite well. So in that, we as a physiotherapist needs to learn one thing: thought, emotions, and behavior. Because thought is one thing that causes a lot of emotions, and emotions results into a behavioral problem, which is catastrophic or painful in nature. So, just understanding one's thought or connecting it to what causes pain or what causes relief of pain, and being with the thought for longer period of time will also result into relaxation and relief of pain. So if the patient is slightly educated, if the patient can understand the different dimension of pain along with the different dimension of his thinking process, because the mind thinks in patterns. So if his pattern of thinking and his pattern of pain and type of pain and time of pain and area of pain and position of the pain and the situation which evokes the pain, all this can be curtailed, then these three areas, that is thought, emotion, and behavior, can be really regulated. And if this can be regulated, okay, usually psychological counselings are done, and but this thought, emotion, behavior thing can be done by a physical therapist, where they maintain a diary and thereby you can write the pattern of dominant pattern of his thinking, dominant pattern of his thought, and dominant pattern of his behavior, which is connected somehow to his pain and is connected to his other symptom also, especially the immobility and the spasm and the edema and the dysfunction. So if he can connect, and if he finds that there is some amount of thought and emotion which is really troublesome and causes increment in the symptom, then changing the thought or changing the emotion. The thought hold for a certain amount of time becomes emotion. Obviously, emotion results into neurogenic deposition of the brain and peripheral nervous system. So sensitization is to the central sensitization, peripheral sensitization also. It's been seen in research quite some time that it results into decrement in sensitization and thereby decrement in pain and symptom. So maybe active assistive physiotherapy, functional physiotherapy, resistance mobilization, some grade of cold therapy, TENS, and psychological counseling, and cognitive behavior therapy. Yes, CBT, cognitive behavior therapy works quite well. Though it is not our quite common our domain, but yes, if it works well with the physician, especially second type of CRPS, where neuropathic involvement is too much, or the third or second or third stage of CRPS, where the pain is not decreasing, but other pain like contracture or the therapy and all. So in that area, especially the matching physiotherapy needs to be initiated so that the pain phenomena along with the range of motion and functional dysfunction can be minimized. So, in my opinion, I have had seen a patient who was 68-year-old Dada. He just had some little injury following which he developed CRPS1. And he was coming to our clinic once, probably after one physiotherapy session. I little bit of some other movement also done, and his symptom increased very terribly, but he was very much angry on us, and then we calmed him down and started doing a bit of relaxation, and then water based exercises, and then ice therapy, and then we put him on TENS and active assistive exercises and told him to do it a little bit of movement, avoiding kinesiophobia, and he recovered quite well. Second patient was probably one GBS patient. One myocardial infection patient was coming to us with CRPS, and all these patients had pain, which was with physiotherapy also it was increasing. So what we tried was in place of giving contraction, we started giving relaxation, and we only told patients to do the movement what he liked, or go to the range where he likes, bear the weight, how much he can do. And with that, he was assured and he was participative in relaxation procedures, especially local relaxation and also central relaxation. So, for both mindfulness technique or some amount of relaxation through contract relax technique, gentle contract relax technique, and some deep breathing exercises, I saw that both the patient, that is CRPS following GBS and CRPS following myocardial infarction, recovered quite well. So, just on a note of sharing and suggestions to all my fellow students and my colleagues, that CRPS is one of the commonest sign and symptoms of associated pain, and as I said, that the condition is quite common, somewhere around 5 to 26 per lakh, and any inciting trauma can result into disproportionate pain. So in clinics, there's a lot of cases might be coming. So we all need to take care of them and see to it that since it is a phenomena of years together and many times uh, multidisciplinary system only works, and here getting multidisciplinary system is all not all that easy. So it becomes the responsibility of the treating physiotherapist that they give their maximum to the patient, interact with the patient, see the patient's problems on day-to-day basis, and change accordingly. And if the symptom is outside the control of our scope of practice, we need to seek the help of other professionals. So with that, I think I sum up the presentation of CRP. Thank you. And now, if there is any question, let me.
Thank you, sir. Thank you. Thank you for being with us here today and taking out some time for us from your busy schedule to provide us such a valuable information. Definitely, this webinar earned a huge positive response, and all thanks to your support, sir. Thank you very much again on behalf of whole Parul team.
Thank you very much. I am sure in case you require any help at any time, kindly call me. I'll be there to help you. Okay, and interact with the student will be my greatest pleasure. I may not be
Yes, sir.
very good technically, so I was not very could finger out and place the titles properly. But anytime if you wish, I'll be there to be part of you. Thank you.
Yes, sir. Yes, sir. Thank you so much, sir. Thank you very much again, sir. Thank you. Yes, sir. You can leave the meeting now.
Okay.
Okay, shall I leave?